Now the forum is open for discussion. Any question?
I have a question regarding CRRT or SLED in ECMO. Sir. Thank you for
Sir,
that
please come.
Thank you for that wonderful talk, sir. I would like your take on use of CRRT or SLED in cases of heart failure or end-stage lung disease based on renal perfusion pressures or other creatinine clearance or other blood biomarkers or parameters so as to prevent AKI. Rather than using them post AKI, can we use CRRT or SLED in a pre-AKI setting so as to prevent AKI based on CBP, systemic arterial pressures and all?
Yeah, I think as already been discussed before, see, AKI is an indication, but it all depends upon the concept of demand as well as capacity, right? Rather than waiting for the kidney to fail completely, right? You always measure the amount of demand, like in the presence of excess fluid overload or solute overload, or the underlying pathogenesis of primary insult, whether it is kidney or non-renal, right? So based on that, you define the CRRT or any modality of renal support.
Yeah, what we have seen is more than systemic pressures, it is the raised CVP which does this damage to the kidney.
That's what, it's a fluid overload, right? One of the most important factor, more than 60 to 85% of the patient on CRRT within 48 hours develop a state of fluid overload. Right?
Thank you.
Yeah.
Well, sir. So how do you control your tracheostomy bleeding after percutaneous tracheostomy?
Basically, local application of Surgisil and other agents were not effective. We used to find a paratracheal leak which used to go down and again cause a blood clot in the bronchi. So what we did, while we always do percutaneous tracheostomy, in percutaneous tracheostomy we then started using cautery. The moment we find a bleeder or a small bleeding, although we used to do a very good cautery before widening the gap, the hole. Point number one. After the tracheostomy has been done and the patient is on ECMO, we used to take a purse string sutures from the skin to the tracheostomy hole. And that worked later, that there was no further bleeding. And of course, the third part, whatever blood was trickling down by the side, we did cryo so that we could prevent occlusion of the alveoli or bronchus and infection.
So one thing, we practice, I don't know how it causes, we put one size bigger tracheostomy. If we put 8, we put 8.5.
More than 7, more than, Pooja will answer that, more than 7.5 it did not went, we were afraid also that way.
Okay. So that has given good result.
Usually what happens is, when you do tracheostomy, we usually take a local with adrenaline and we put a small around 100 milligram of tranexamic acid also and then infiltrate. So you don't get usually bleed on the day one. What happens is usually when you try to make them awake, okay, and with their neck movement and their breathing, okay, then the bleeding starts. So usually the tracheostomy typically bleeding starts after 48 or 72 hours of when you try to make them awake. And when that it happens, again we try to infiltrate again the local with adrenaline and that. Or if we find that a hole is big enough, then we might take suturing. Or sometimes we have put even 9-number tube also. So usually we start with the 8-number tube. But if required, we go for a higher size tube. And then you put a higher size tube and usually that bleeding stops. Some of the time we found that there is a bleeding coming from the inside of the trachea, just behind the, within the tracheostomy tube part. once or twice we have done put a surgery cell around the tracheostomy tube and put it inside, and then it helped and it worked. We have not done it regularly, but in 1 or 2 cases we have done that. Just to put a surgery cell around the tracheostomy tube, put a one size higher tube and put it inside, and then the bleeding stopped. So it basically, you need to find out from where the bleeding is coming basically. It's just from the skin coming, whether it is coming from the inside. Sometimes, in 1 or 2 cases, we found that the bleeding was above, somewhere near the vocal cords. Okay. So again, then you need to pack the vocal cord with the either gel foam or surgery cell, and then room it after 48 hours or something, and then it helps. You just do a blind packing of nasal and blind packing of mouth does not help.
It never, ENT surgeon never helped us.
Yeah.
So do you do regular brushing of teeth on ECMO patients?
If they are awake, we don't do brush, but we just take a gauze piece and clean the teeth and everything.
Because recently I have gone through how to go for the oral hygiene, that they have discouraged don't brush the teeth.
Yes.
Because that can lead to
bleeding.
those not so good looking bleeding from there. So
Yes,
just
yes. Then it will
clean
going to be
it with
difficult
all
to
this.
control it also.
I mean, regarding this, I want to ask Dr. Arpan Murli or Dr. Venkat that during this ECMO in COVID era, did you find more oral and the oral nasal bleeding? No, more incidence of oral nasal or tracheostomy bleeding compared to other? No.
No, not actually. In fact.
If we categorize, okay, fine. If we categorize the areas of bleeding, I found slightly increased tracheostomy bleeding after percutaneous tracheostomy in COVID. That surprisingly, that starts after 36 hours. What he was telling, and almost 90% are them not managed by doing this cautery and surgery cells. I had to put a bigger one. I don't know, from the sides of the muscle starts oozing and just increase pressure and stopped it.
Yeah, just you put a higher size tube, it compresses and it.
And there is a blunt instruction I have given to the nurses that no suction, oral suction to be done. All the secretions to be cleaned by that gauge piece and all these things. Because if starts bleeding from any gum and this thing, it becomes a nightmare. And when the patient party looks on the video calls, if everything is fine, only blood trickling from this side, they found the patient is not doing well. So this oral bleeding is a nightmare for me. So that's why I go through and they asked me not to brush the teeth.
Thank you. Just to comment on this, tracheostomy standard we use is 8 for female and 9 for male. That's the standard we use, the maximum possible. Yes, we do encounter troublesome post-percutaneous tracheostomy bleeds. Most of them do settle with stopping heparin and coagulation management. Even after that also we have seen bleeds which were quite troublesome to the extent that you require to transfuse that degree of loss. But once we involve the surgeon, cardiac surgeon is the one who handles that. So once we involve them, and usually what they do, we convert into the ET tube and then we leave it the place, entire area to them. But once they step in and once they handle, that never troubled after that. Unless you are seeing someone who is terminally ill for extremely coagulopathic, other than that becoming a persistent trouble, no. Yes, once they take out the tube and manage, that settles down.
See, I think once we had a situation where we removed the tracheostomy tube, there was a bleeder, cauterized, then later we put back the tube. Otherwise, most of the time you could manage
it. Settles, yes. And what was troubling was this nasopharyngeal bleeds. And that's mostly due to the Riles tube insertion and where there is a propensity to bleed. And at times they trouble quite badly where we have to involve the ENT teams. They will come, they'll pack, and that packs have been kept for 48 to 72 hours. Then there was one case where after they removed, again it bled, and then again it packed. But eventually that is settled. In that case, it is settled. So what is your strategy? Do Riles tube before ECMO or Riles tube after? If we have an option before, but if we long run, at some point we need to change. If possible, give a break. And Freca tube, I think, has lesser risk of bleeding, lesser risk of injury and bleeding. Yes. And I have a question for everyone. We do see that we have the standard indications for oxygenator change, whether low PO2, carbon dioxide, transmembrane. If we leave all that apart, especially if you are running a heparin-free or low heparin ECMO, we do see that at some point the fibrinogen starts going up and then it starts coming down. At that time, you see the picture of consumptive coagulopathy. We here almost do all the standard coagulation tests every day for all the cases. You see the consumptive coagulopathy slowly setting in, the platelets coming down, fibrinogen coming down. At that point, even though they may or may not have any significant or even major bleed. So in that cases, are there any clear institutional practices or guidelines to change the oxygenator, I mean the entire circuit? Because it happened that whenever it comes down after seeing the first cases, when it becomes an alarming level, we go ahead and change it. That's when we know clinically probably end of life for this circuit. And that makes a difference.
No, if there is
coagulation picks up after that, clearly.
If you can see the thrombus or a fibrin in the oxygenator, then it needs to change. If they are developing a kind of a DIC picture, then you need to change it.
Seeing in the oxygenator, if we see large clots, yes, it is, but not able to see clots, again, I think is falsely reassuring. A lot of times it happens that you see that oxygenator is bad, but we may not be seeing a lot of visible clots both on pre and post membrane.
See, the first is, if you can see oxygenator clots, you have to change. That is number one. Number two is, if the patients, if the delta pressures are going higher than what it was before, okay, and there is no obvious reason for platelets and fibrinogen to go down, you rule out, you are sure that there is no sepsis, then in that case again you need to change. Even the PO2 is okay post oxygenator, but in that case you need to change it. So are we changing the oxygenator at a regular interval? No, not at a regular. If there are, only when it is indicated. One is raised delta pressure, visible clots, and if with patient is developing thrombocytopenia gradually, then in that case, yes, you have to.
So one of my patient had a 81 days of ECMO run, and she went through only one oxygenator. But I could not say it in different scientific forums because people will catch me because 81 days you have run the thing.
See, oxygenator life, fibrin life, fiber life is endless unless it gets clogged. It's not that after 40 days the fiber life is going to, or the gas exchange at the fiber level is going to be less. If it will get less only if there is a clots inside. So if there are no clots, then you can continue for a number of days, whatever.
So that's what I'm telling you. That we can quote this in civilized forums that we have run the single ECMO.
Yes, definitely. Definitely. No, see, the companies say because they are bounded by the FDA. So they say that FDA has given approval for 30 days. If you see all the pumps, they have written that it is approved for 5 to 10 days only.
See, there is a reason for that, and I know that because I'm developing a VAD. See, for you to prove anything, you have to demonstrate that first in an animal model. For instance, if you want to show safety of an oxygenator for 3 months, you have to keep that in an animal sheep or a pig for 3 months. And trust me, keeping anything in an animal model for 3 months is not easy. So even for a long-term VAD, HeartMate 3, all that is required is 3 months the animal has to live. So at the end of the first month, if the animal is alive, you automatically get permission for short-term VAD. You know, it's a lot of it is regulatory because of proof rather than the fact that they break down at the end of the period.
So officially they cannot say that you can continue the this particular component for this number of days unless they get an FDA approval. If you see, only Make has got an FDA approval of say 30 days, but rest of the PMP pump, oxygenator, we still use, but they don't have an FDA approval for 30 days. They usually have 10 days or 15 days. Centimec has got 40 days approval. Yeah, they don't have oxygenator. Yeah. Yes.
But you also had a situation where you wanted to change an oxygenator and oxygenator is not available.
Yeah.
All of us have faced this.
Yes,
All of
yes.
us have faced this.
That
So
has happened.
what is the judge going to tell you? It's easy for him to sit in his high and mighty court and give you judgment. Here, you know, there was a time when we're desperately short of oxygenators.
Yeah, I understand. But then they will call one of us from one of us to be expert. So we will maintain the same thing. Yeah. See, as long as the people who are practicing, they are in conscious, then there should not be a problem. Yeah.
Sir, last question. So what about citrate anticoagulation, sir? Like in CRRT, if you have any issues with heparin, we go for a regional citrate anticoagulation, right? Why not a similar strategy we followed in ECMO also for the extracorporeal circuit?
I'm not sure they are not. No studies for RCA done in ECMO patients, but even with in patients with increased risk of clotting with CRRT in combination with, we do separately for CRRT alone, but that is, I think they have not tested in ECMO patients. I don't know why.
You are talking about anticoagulation for ECMO,
ECMO, sir.
using
Not in
citrate.
CRRT.
Yeah, that
Similar
see in,
strategy, why not it be followed
yeah,
in
yeah,
ECMO
in
also?
CRRT they get only 150 ml of blood, and they give citrate. At the end you give calcium. So, but in ECMO you are giving a flow of 4 liter, 5 liter. So how much citrate you give and how much calcium you give? You'll have a calcium toxicity or citrate toxicity. So that's why it's not tried. I don't know whether trying to, I mean, somebody is doing some.
Nobody is working on that.
Thank you, thank you.
For citrate, there is no documentation on it.
I have a comment to make for Dr. Goyal. You know, there is recently a lot of interest in, you know, this factor 11A. Factor 11 is a factor which gets activated and then starts the extrinsic pathway. And it's not involved in bleeding. So I think Karolinska Institute in Sweden first came out with an antibody specific to factor 11A. Now there are synthetic polypeptides. So that seems to be a potential new therapeutic initiative where you can actually have anticoagulation without increasing the risk of bleeding.
Information to be said.
So if there are no further questions, we will announce this session's closed. Thank you, all the speakers and the faculties.
Thank you everyone.